Hello guys, good evening. This is Mr. John from MJ Healthcare Consulting, and right now we are on the Nurses Corner Net page where we bring to you review questions for DOH, MOH, and DHA. So we are treating part 2 of the previous class where we did the care of the client with PEG tube and NG tube. So I'm going to share the link below so that you'll be able to go through the previous video. So today we're going to do respiratory system tubes. I'll give you a briefing as usual. Then we have some questions to answer later on. I want to make sure this video goes between 30 to 45 minutes, okay? So I'm going to be a little bit fast, but bringing in the necessary points that you need. Like I said before, we are not treating topics as if we are in nursing school. We're just bringing out the points that are needed to answer your examination questions. So remember, you're preparing for DOH, MOH, and you have to cover the 3 years, 4 years program. So you should understand that in each topic, you're picking out the most important points. So that's what we're doing here, okay? So you might discover that a lot of things are left out. We go straight to what you need to know for your examination purpose. Let's get started. So we're going to treat 2 tubes here, care of the client with 2 tubes. Either the client is with endotracheal tube or with tracheostomy tube. And the endotracheal tube, you can have 2 types, either orotrachea or nasotrachea. Oro means from the mouth. It means the tube is passed from the mouth to the trachea, okay? We can call that airway tubes. So you can either have it from the nasal to the trachea. These ones, they're a little bit smaller. So the second part, we're going to see tracheostomy tube. Tracheostomy tubes are passed mainly through a surgical opening from the trachea in from here, on your neck here, there's this area into the trachea, okay? From here, when you go in, you go into the trachea from this outer part into the trachea, okay? So the tube can either be temporary or permanent, that is tracheostomy. Meanwhile, most often the endotracheal tube is always temporary. And so let's look at what can be some of these respiratory issues or medical conditions that will necessitate that we pass this tube into the patient. So what are the indications? So this tube can be put in place to maintain the patent airway, okay? And you want to maintain airway of the patient, maybe to carry out some procedures. The patient might be having difficulty breathing or whatsoever, or there's a upper respiratory issue, and you want to maintain the airway, so you're bound to pass the endotracheal tube, okay? Now, the second point could be when the client needs mechanical ventilation. For those of you working in ICU, you should be familiar with some nursing care of a client, of a client on ventilation, okay? Mechanical ventilation, that's a whole area on its own. We're going to see more of that when we shall be treating part 3 of this topic, which is care of clients with chest tubes, okay? Chest tube, we see most of them that are connected to mechanical ventilation. We can also pass this tube to clients maybe who are requiring artificial airway, for a longer time, for about 10 to 14 days, and will be bound to put past this tracheostomy tube. And here you will see how the first part we are going to treat is endotracheal tube. Okay, this is how it look like. There's a balloon here and here. So this is an airway. Okay, this one is orotracheal tube. Yeah, this one goes from the mouth into the trachea. There's a syringe here, and this one is the nasotrachea. Okay, and then you have the laryngoscope here. You use it to open the airway to get access to the trachea. Then before you can pass in the airway itself, the endotracheal tube itself. Okay, so you hold your left hand, and then you aim at the trachea. Now that is how they look like. I just want you to be familiar with them, so that we shouldn't be talking on something that you don't even know how they look like, right? So now, like I said, we are treating most importantly nursing intervention, nursing care, what the nurse needs to know, okay, when a client is on these tubes, okay, some troubleshooting, what you need to do when these tubes are in place. That is what we are much more focused, okay. Now, so the first thing we can confirm that the endotracheal tube is in place is by the chest X-ray film, okay? You know, there are so many ways. Maybe you say you might use a stethoscope to listen to the sound from the chest wall, you know, to know whether it is in place, okay? It's not bad. But we're going to see that also when we are talking about the tracheostomy tube. We also saw this when we treated the PEG tube and the NG tube, that the most and perfect way to check for the correct placement of this tube is a chest X-ray, because it actually shows you how this tube is inside, and you can actually identify from the X-ray film itself. Now, it has to be 1 to 2 centimeters above the carina, okay? So through the X-ray film, you'll be able to see that. Now, we can access the first point. You are confirming that it is in place, right? It is in place. And you can actually access again by auscultating both sides of the chest while manually ventilating with resuscitation bag, what we call the ambu bag. Now, this is how it is put in place. You can see from here, this is the laryngoscope, this is the endotracheal tube here itself, and you pass it. Now, it has to end just above the point where the trachea divides to the bronchus, to the bronchi, okay? To the bronchi. Now, the trachea goes in and divides into 2 bronchi. So we have the right bronchi, which is straight, and the left bronchi, which is tilted to the left. Now, there is a method you need to know if actually it is inside. When you ventilate, you can see from this photo, there's an ambu bag here. When it is inserted, you have to connect this ambu bag to this tip, and then you inflate. Now, you have to watch for the chest rise. Now, if the chest rise is only on the left lung, it means the tube is in the right lung, okay? The tube has gone through the right bronchus. Okay, very, very important. So we're saying that if breath sounds and chest wall movement, yeah, we say the chest rise, chest movement, they are absent on the left, sorry, they are absent on the left, it means the tube is on the right. Of course, it means the tube has gone into the right bronchus, and so you are inflating the endotracheal tube and the air is going but to the right, okay? So there will be no chest rise on the left, so there will be absence of chest wall movement. This is a very important area. You need to take note. I take it over again. When you inflate this bag, the amble bag, and there's an absence of chest wall movement on the left side, meaning the left lung is not inflated. Therefore, you have passed the endotracheal tube into the right main stem bronchus. It has gone to that because the right side is straight. What you need to do is just pull it a little bit backwards. You have to just pull it. Now, you also have to perform auscultation over the stomach, okay, to rule out what we call esophageal intubation. Now, if you also inflate the bag, okay, but you ventilate the patient, but you find but abdominal movement. You find but abdominal movement. It means the endotracheal tube is instead in the stomach. That's what we call esophageal intubation. It means you instead pass the endotracheal tube through the esophagus. You did not aim the trachea. You did not pass it through the trachea. It instead went into the esophagus, and that's what we call esophageal intubation. This area is very much important. You can see from here, this is the esophagus, and it is possible that if the laryngoscope do not open the airway very well, do not do it perfectly, you might mistakenly pass the endotracheal tube into the esophagus. And when you ventilate, air is instead going into the stomach, and you will find both the movement, abdominal rise and fall when you ventilate. So you have to be very careful. So like I say, if the tube is in the stomach, loud breath sounds will be heard over the stomach than over the chest. Yes, you will have abdominal distension will be present. You have the rise and fall of the abdomen. It means the tube is instead in the esophagus. Now, when the tube is properly inserted, you have to secure the tube with IC tape, okay? Monitor the position of the tube or the tube. And then you monitor the skin and mucous membrane. Of course, you have to do that. You suction the tube when needed. Now, there is a question that always comes that a patient on endotracheal tube or on tracheostomy, we're going to see that, and the doctor orders 8-hourly suctioning. No, it's wrong. There is no specific timing for suctioning. It is PRN as needed, okay, when necessary. So there should be no specific time like you suction the patient every 2 hours, every 4 hours. No. The right way is when needed, the right option. So move oral tube to the opposite side of the mouth daily to prevent pressure and necrosis of the lip. Yes, this is very important. And this should be done with 2 nurses. Prevent dislodgement and pulling of the tube by the client. Maintain cuff inflation at a pressure of 15 to 20. This is very important. I told you this endotracheal tube has a balloon here. Now, when the tube is inserted, as you can see here, this balloon stays out. It is connected, goes inside. We want to maintain the cuff, the pressure, okay? And you use a manometer to connect at this tip, and then you have to inflate it. It should be between 15 to 20 millimeters of mercury, okay? And you have to monitor that at least every 8 hours to be sure that it is inflated. Don't deflate it unless you want to extubate. You want to remove the endotracheal tube. Okay. Now you have to keep the ambo bag, the endotracheal tube, and all necessary materials needed for the care of this client at the bedside, because at any time anything can happen. Maybe dislodgement. This patient is this action is an emergency. Care has to be taken very serious. You have to attend to the patient immediately. Remember, we are talking about the airway here. So you have the ABC. A is the airway. You always have to attend to that first. So as when you're taking care of a client who is on these tubes, make sure you have extra tubes at the bedside and whatsoever that is needed to give air to the client when necessary. Let's look at extubation. Means you want to remove the tube. Extubation. What we saw before, or what we talk about intubation and then the care. Now we're talking about extubation. The doctor orders that you have to discontinue the endotracheal tube, you know. So what will you do? You just go to the client and then you just pull out the tube like that, just like that? No, that is not what you have to do. The first thing you have to do, of course, normal information about what you have to do and identify the patient, of course, that is okay. Now, you have to hyperoxygenate the client. You have to hyperoxygenate the client because at the time of the removal of the tube, the patient is bound to go into desaturation. The patient saturation is going to drop a bit. The saturation is bound to drop a bit. So you have to hyperoxygenate the patient, give 100% oxygen. Now, you place the patient in semi-Fowler's position, okay? Last time I said semi-Fowler's is about 30 to 45 degrees. You have to place the bed at 30 to 45 degrees, and high Fowler's is 60 to 90. 90 degrees is like sitting upright. The patient should be fully upright, like sitting. Okay. Then you deflate the curve, have the client inhale, and at the peak of inspiration, remove the tube, suction the airway via the tube, pulling it out. Okay, that is what you have to do. Instruct the client to deep breathe to assist in removing accumulated secretion, apply oxygen therapy as ordered, okay, when needed. Monitor respiratory difficulty, e.g. stridor. And stridor is high-pitched sound that is noticed that the patient you hear through auscultation from the upper airway of the client due to airway obstruction. Okay, this is what we call stridor. It's different from wheezing. Wheezing is the pitch sound of wheezing is higher than that of stridor, and it comes from the lower airway for wheezing, which could be from conditions of asthma. Okay, it's also a lower airway obstruction, but stridor is an upper airway obstruction. Now, when in the course of extubation, when the patient has respiratory difficulty, please notify the healthcare provider immediately, okay? Notify the healthcare provider immediately. Inform the client that hoarseness or sore throat is normal. Okay, when you remove the tube, you know, the airway is irritated and the sound might not be a little bit clear, you know, the patient might feel some sore throat. Inform the client that you will have to experience this for some few hours and it is normal. It shouldn't be a big issue, okay? You have to educate the patient about that. We're talking about hoarseness and sore throat, not not blood, okay? If the patient is coughing out blood, no, you need to take care. There is a problem. When you extubate a the patient shouldn't cough out blood, means there is an issue somewhere which attention needs to be taken into consideration. Okay, so this is the end of what we need to know in the care of a client with endotracheal tube. Okay, we will move to the tracheostomy and then we will see some questions. Okay, now we say this is how the tracheostomy looks like. It also has a balloon here. You can see this blue part is the balloon. And this is a patient already on tracheostomy tube. I told you a few minutes ago that it is passed from here into the trachea, and there's an inner cannula here, there's a tie here, you know, they apply a tie to keep it fixed, you know, and this nurse is suctioning the client, okay, you suction from here. And what you also need to know how to take care of this, there's a stoma here. Stoma means the site where the tube is inserted. There is a wound there, which some secretions coming out, you know, so proper care has to be taken. And this is an aseptic technique. Okay, it's an aseptic technique, especially when it comes to cleaning of the inner cannula. Now, most often there is what we call aseptic non-touch technique, which is what can be applied. It means the procedure, what I can put in simple terms is like, it is a clean and sterile procedure, okay? Because you don't need to put on sterile gloves, but you should not touch specific parts, okay? Those parts that you have contact with the clients, those parts have to be kept sterile. That's what they call it, aseptic non-touch, non-touch. You don't touch. So those are the areas that have to be kept sterile. You don't touch that. So it's just like you might be asked if the care of tracheostomy is it a clean procedure or a sterile aseptic technique. Of course, it is a aseptic technique. It is. And what precautions should you take? Are you taking just universal precaution? When we talk of universal precautions, what we mean is, you know, just wearing the normal clean gloves, hand sanitizer, you know, after taking care, touching the patient or the bedside, you know, those normal procedures that we do to prevent, you know, hand hygiene stuff, you know. But this is not only what is needed in the care of a client with tracheostomy. This is not only what is needed. You have to go beyond this. You have to go beyond this. So aseptic technique is what is needed to care for this client. So let's say we have this client in place with the tracheostomy and you are taking care of this client, this patient. What do you do? Nursing interventions. This is what we're going to look right now. Let's go. So you have to assess respirations and for bilateral breath sounds. Okay. You are inserting a tube into this client's trachea, right? You want to give supportive oxygen. Of course, this is where the patient is breathing. Now that is the patient airway. That's the patient airway. And you have to always check to be sure that the tracheostomy is in the right position. Like we saw in the endotracheal tube, we said it has to be above the point where the trachea divides into two bronchi, right? Now, this is the right point where it has to end. And so when you check for respiration, and also you should be able to find bilateral breath sounds, means you should auscultate and make sure that both lungs are ventilated. Both lungs should be ventilated. What did we say before? If there is no breath sound on the left side, it means the trachea is in the right main stem bronchus. That's what we said, right? It's the same principle here. The same principle here. Monitor ABGs and pulse oximetry. Yes, ABGs here we're talking about the oxygen. We're talking about acid-base balance. We're talking about the carbon dioxide, the carbonate. You have to monitor that. Encourage coughing and deep breathing, maintaining semifowlers to high fowlers position. Okay, you have to maintain that. Monitor for bleeding, difficulty with breathing, absence of breath sounds and crepitus, which are indications of hemorrhage and pneumothorax. Yes. You have to make sure that you check for this. If there's bleeding, care has to be taken. If there's absence of breath sound and crepitus, something is wrong. Maybe there's bleeding somewhere inside, or there's pneumothorax. Suction as needed. Suction as needed, not 4 hourly, 8 hourly. Suction as needed. Now, before you suction, you have to hyperoxygenate before suctioning. Very important. Monitor cuff pressure. And what did we say about cuff pressure? We said it should be 15 to 20. Assess the stoma and secretion for blood or purulent drainage. Administer humidified oxygen as ordered. Yes. So most patients who are on tracheostomy, they are connected to oxygen cylinder, and this oxygen has to be passed through, has to be humidified, means it has to pass through water. Most often, is it sterile water? Yeah, sterile water, because the patient is breathing air that is passing through this water. And this is also to prevent dryness of the airway. This air is going to the patient. So the water has to be sterile water. You cannot imagine humidified water is contaminated. The patient is breathing, okay? And most often, most cases, they will say it must not necessarily be sterile water, because they put water bottle, normal one that we drink, and they put it there. So when you have your oxygen cylinder, there is there's an area there where you have water always bubbling there in one small container there. That's what we say. You are administering humidified oxygen to the patient, okay? You find it there bubbling. You don't just pass out dry air to the patient like that. It's not good, you know. Follow healthcare providers' prescription and facility policy for cleaning trach site and inner cannula. Yeah, you have to follow that. Like I said, cleaning the inner cannula is an aseptic technique. Obtain assistance in changing the trach ties after placing the new ties. Cut and remove the old ties holding the trach in place. This is very important. These are the ties here. You always make sure that the trach is not dislodged at the time of changing the ties. Okay? Before you start calling the ambulance. Keep resuscitating bag, clamps, spare trach at the bedside, like we said before. If a trach dislodges, the initial nursing action is to grasp the retention sutures and spread the opening manually, then resuscitate and call for help. Yes. You have to grasp the retention sutures and spread them open. Resuscitate, okay, ventilate, then call for help. Never invert a plug or a cap into a trach tube until the curve is deflated and the inner cannula removed. You don't do that. So these are the basic things that we have to do when we have a client on trach tube, okay? These are the things that as a nurse, you have to do. You have to do. Let's see how we can answer some questions. Like I said, I do not want this class to be long. Let's get to some review questions. Question number one. Question number one. Okay. Your patient has an endotracheal tube. You are assessing placement by listening to the lung sounds, and you notice that the breath sounds and chest wall movement are absent on the left side. Yes. Yes. What is usually the cause of this? I talk about this, right? I explain about this over and over. Let's see question option A. A pneumothorax may be developing and a start chest x-ray should be ordered. Okay, let's see option B. The tube is not above the carina and must be reinserted. Really? Let's go. The incorrect size tubing was used. Let's see. The tube may be displaced in the right main stem bronchus. Yes, we said so, right? This is the right answer. D. I explained when we were doing endotracheal tubing, and I also explained in tracheostomy. Over and over, I explained that. Searching, there is an option here that search. I cannot see what I'm searching. The answer is D. Okay. Question number 2. Your patient is ordered a chest x-ray to confirm endotracheal tube placement. We agree that the best option is chest X-ray. The tube should be how many centimeters above the carina? Yes. So when a chest X-ray is taken to to confirm the placement of the endotracheal tube, it should be A, 0.5 to 1.5 centimeter, B, 1 to 2 centimeter, C, 1 to 4 centimeter, D, 2 to 3 centimeter. What's the right answer? What did we say in the notes? The right answer is B, 1 to 2 centimeter. We made mention of that. Let's go back to our notes and see that. This is it. We say confirm placement by chest X-ray film. Correct placement is 1 to 2 centimeter above the carina. We said that. 1 to 2 centimeter. The carina is the point where the trachea branches into two bronchi. Okay, that is the carina. So it should be 1 to 2 centimeter above. You can see this gap here. Yeah. Yeah. If you continue inserting it, it will go into the right bronchus. It will go into the right bronchus. Yeah. Good. Question number 3. While changing the tapes on a newly inserted tracheostomy tube, the client coughs and the tube is dislodged, which is the initial nursing action. The initial. Another word that can be used is what should the nurse do first? And I made mention of 3 things. What should the nurse do first? Which is the initial nursing action. What should you do? Sometimes they might give you options that are correct and they ask you 1 or 2 options is correct and you have to choose all of them. Okay, but when they tell you, they say you should choose what you should do first. It doesn't mean that the other options are not right. They are right, but you have to do something first before doing. There should be an order. Okay, let's see if we can recall. Call the healthcare provider to reinsert the tube. Is that the first thing you have to do? The tube is dislodged here. Grab the retention suture to spread the opening. Is that the right thing? Let's go. Call the respiratory therapy department to reinsert the tracheostomy. Did we see that? Is it necessary? Is that the first thing to do? Cover the tracheostomy site when a steroid dressing, with a steroid dressing to prevent infection. We said, grab the retention suture to spread the opening, resuscitate, and call for help. So B is the right answer. What should you do? Grab the retention suture to spread the opening, resuscitate, okay, ventilate, and call for help. Let's go back to our notes. It's right here. We said so, right? If a trach dislodges, the initial nursing action is to grab the retention sutures and spread the opening manually, then resuscitate while calling for help. Yes, you have to do that. That is what you have to do. In that order. Okay, B is the right answer. Question number 4. The nurse is caring for a client immediately after removal of the endotracheal tube. The nurse should report which sign immediately if experienced by the client. This is extubation, right? Removal means extubation. You are removing the tube. And what did we say? First aid, hyperoxygenate, then you remove. When you remove, the patient might feel something which is normal, but when you find this is not normal. Can you recall that? So the question is asking us, the nurse should report which sign immediately if experienced by the client. You should notify the healthcare provider. If the client A experience stridor, B occasional pink tint sputum, C respiratory rate of 24, D a few basilar lung crackles on the right. What did I say before? Stridor, A is the right answer. I said stridor is high-pitched sound from the upper airway, indicating airway obstruction. Okay? Stridor. You should inform the healthcare provider immediately. Yep. Okay. Question number 5. You are assessing your patient with an endotracheal tube and note that the patient is able to make verbal sounds. What is the most likely cause? Verbal sounds, and the patient is on endotracheal tube. Is the patient supposed to make verbal sounds when on endotracheal tube? You have to ask yourself this question. So if the answer is yes, okay. If the answer is no, then why is the patient making verbal sounds? There should be a question mark somewhere. What is happening with the endotracheal tube in place? So before we go to the answer options, the patient is not supposed to make verbal sounds, okay? Some little amount of sound can come out, the patient can murmur, you know, no issue, but not verbal sounds like, you know, it's not supposed to happen. If it does, then there is a problem. And what is that problem? That is what this question is asking. What is the most likely cause that a patient is making verbal sounds while on endotracheal tube? Let's say there is an occlusion, then there is verbal sound. There is a leak. Okay, let's go. None of the above. This is normal. No, it's not normal. The tube is displaced. If the tube is displaced, do we have verbal sound? Displaced to where? Into the right bronchus or to where? If it is displaced to the right, then there's absence of breath sounds on the left side, right? So, but we're talking of verbal sounds. So if the patient is making verbal sounds, it means there is a leak. There is a leak somewhere. So the right answer is B. Okay, the right answer is B. Occlusion is just like we're talking about some obstruction, you know. Instead, we will have stridor, like we saw in the question above. Okay, the answer is B. There is a leak. The leak is the cause for the patient making verbal sounds. Question number 6, the patient with a tracheostomy needs to be suctioned, what would you do first before suctioning the patient? This is a priority question. Initial action. First, what you have to do. Question interpretation is very important. It means there are other activities that you can do which are okay. But what should you do first? Priority. So before you suction, you should, we mentioned that, right? A, disconnect pulse oximetry. Like seriously? Hypoxenate the patient. Assist the patient into Sims position. Have the patient bear down. Disconnect, no. Instead, the pulse oximetry has to be in place. It's in place, you cannot disconnect it. B, hyperoxygenate. Why? That is the right option. You have to hyperoxygenate the patient because in the course of suctioning, the patient will go into desaturation, okay? Patient saturation will drop and you can actually see that on the pulse oximetry. You can actually see that. So the pulse oximetry has to be in place. So the first thing to do is to hyperoxygenate the patient. B is the right answer. Question number 7. After the client had tolerated the weaning process, the physician ordered the removal of the endotracheal tube and will be shifted into a nasal cannula. Which of the following findings after the removal requires immediate intervention by the physician? Yes, you have to wean. Weaning is from the time the patient stops using the endotracheal tube to the time the patient finally goes into using his or her own airway. So you don't just stop the patient from using endotracheal tube and then so you have to move from the endotracheal tube into nasal cannula, okay? The patient will still need some supporting oxygen. And then finally, stop giving oxygen to the patient. That's the weaning process. Now, the patient has tolerated this process. So the physician has ordered that the endotracheal tube be removed because oxygen was not given through the endotracheal tube again, but it was still in place. So they were using, the patient will now move into nasal cannula. So they've observed the patient for some time without giving oxygen through the endotracheal tube. We will remove it and then put the nasal cannula and then we observe you again and then we finally stop it. So this tube has been removed and we have experienced this. So what did I say about that? I said, when we remove the endotracheal tube, we should inform the patient that the patient might feel some sore throat, some hoarseness, it's normal. But if the patient coughs out blood, it is not correct. If you find out that the patient is coughing out blood, maybe in the course of removing the tube, maybe you injured the airway or something. Yeah, it is not correct. So action has to be taken. My discomfort, neck discomfort is okay. Sore throat, okay. Hoarseness of the voice, okay. It will go with time. But coughing out blood is not correct. So the physician has to be informed for immediate intervention. So C is the right answer, coughing out blood. Question number 8. A nurse is supervising a student nurse who is performing tracheostomy care for a client. Which of the following actions by the student should the nurse intervene? Yes, this is a question on delegation of responsibilities. You are the supervising nurse and you have some student nurses in your ward, and you have assigned a student nurse to go do tracheostomy care for one of the clients. And when you assign, give out delegation, you have to make sure that the information is concise, is clear, and you have to supervise and you need to have feedback and correction. So you are at the bedside and you are observing the student nurse carry out this procedure. So the question is saying that, what will you intervene when you find the student nurse doing? It means when the student nurse does something wrong, you have to intervene. Question interpretation. Which of the following actions by the student should the nurse intervene? Meaning the answer options, 3 or more of the options are okay, but you have to intervene on something that the nurse is doing, which is not correct. On the wrong option here is the answer, is what the question is asking you to choose. Let's see option A, removing the inner cannula and cleaning using universal precaution. What did I say about universal precaution? Universal precaution, hand hygiene, wearing clean gloves, hand sanitizer, washing of hands. These are universal precautions. Is this what we do when we are removing the inner cannula of the tracheostomy tube? Let's keep the question there. B, suctioning the tracheostomy tube before performing tracheostomy care. Correct. We saw a question like that. You have to do that. Changing the old tracheostomy ties and securing the tube in place. Yeah, you have to do that. Replacing the inner cannula and cleaning the side of the stomach. Yeah, you have to do that. So A, you do not remove the inner cannula and clean it using universal precautions. You have to clean it using aseptic technique, okay? So when you, as the nurse supervisor, sees the student nurse doing this action, you have to intervene and stop the student nurse. Then explain the procedure and explain and tell the student nurse what to do rightly. A is the right answer. So we've come to the end of this course, and I hope it did help. I hope you grabbed some points. I hope I tried my best. I think it's exactly 1 hour. I wanted it to go for 45 minutes, but I think I spent a lot of time explaining the rationales, also why this option is correct and why the other options are not correct. When you answer questions, like some of you who have PDF questions with answers already marked, you don't go read the question and then understand the answer. You should understand also why the other option is not correct, because they will use that same question and ask the other way around. And then if you do not understand why the other option is not correct, then you find that same question and you will fail. You don't expect the same question to be asked, word to word. No, you are supposed to read and understand why this option is the right answer and why this other option is the incorrect answer. So you have to know that. You have to know that. Okay, guys, thank you so much for watching. We're trying to build our YouTube channel. Please subscribe, like, and share our work, and let us know which topics you want me to talk on. We will have to complete part 3 of this care of clients with tubes. which is care of clients with chest tubes. Okay, we're going to see that. Then from there, I would like to work on what you want me. If you're preparing for your exam and you're facing some difficulties, you have some topics you want me to handle them, please comment in the comment section. Let me know, and also share our work. I'm going to share the link of the previous videos so you can watch. Thank you so much and do have a wonderful day. Bye-bye.